Chapter 9, Interpretation of the Spirometry Test Result. So we're going to carry on from Chapter 8 here by going on from steps 1 to 6, right on to steps 7 to 10. Now, step 7 is interpretation. We are going to look at the quality and data validity. We're going to assess our graphs, assess the numbers, look at bronchodilator responsiveness testing, grade the impairment, then document and put our comments on the report itself, compare to previous tests, record and report, and store our test results. So at the end of this chapter, you should be able to understand, recognize, and interpret normal and abnormal, obstructive and restrictive and mixed spirometry. You should be able to describe and use a step-by-step approach to interpreting the test result. You should be able to use a basic interpretation algorithm. You should be able to grade the severity of an abnormality using percent predicted and Z-scores. You should be able to record and report the test correctly and describe how to store the test results appropriately. So now that the validity of the data has been established and the best values identified for interpretation, spirometry interpretation should be clear, concise, and informative. A mere statement of which values are normal or low is not helpful. The final interpretation needs to take into account all the false positive and false negative information from the quality of the blows and then the actual test results themselves and how they compare with reference values. So lung pathology almost exclusively results in abnormally low parameters in spirometry. And the key parameters that we use when we look at interpretation are the FVC, the FEV1, and the ratio of the FEV1 to the FVC. Now, alternatively, we do use Z-scores, but alternatively to Z-scores, if your spirometer does not give you lower level of normal in Z-score, you can use percent of predicted. So when it comes to classifying abnormalities, abnormal lung function can be broadly classified into obstructive, restrictive, and mixed spirometry patterns. In an obstructive lung impairment, there is a problem with flow and the FEV1 is reduced in relation to the FVC, and this is described by the ratio of the FEV1 to the FVC. The FEV1 and FVC will be reduced in a child with any kind of obstruction in the airways, caused, for example, from bronchoconstriction of the airways, occluded with secretions, for example, in bronchiectasis. In a restrictive impairment, there is a problem with volume and the FVC is reduced. In children, low lung volumes may commonly be related to effort and technique, which should be extra carefully assessed. In obstructive lung disease, a child will have shortness of breath due to difficulty exhaling all the air from the lungs or narrowing of the airways inside the lungs. So the exhaled air will come out more slowly than normal. In restrictive lung disease, children cannot fully fill their lungs with air. The lungs are restricted from fully expanding, and restrictive lung disease most often results from conditions causing stiffness of the lungs themselves. Let's start by looking at all of this by looking at a normal spirometry result first. So as I said, a normal spirometry result does not actually exclude pulmonary disease. If there is a high clinical suspicion that there is lung disease, the child must be referred for other complex lung function testing or in conjunction with other investigations like chest x-rays, for example, blood tests and other. Referral to a respiratory physician might also be an option if you are worried about the child and the spirometry shows a normal result. An example of a normal spirogram and a healthy airway is shown in figure 9.1. So you can see there the shape of a normal flow volume and volume time graph and showing that the airway size and the lung volume is completely normal. So using figure 9.3, there are flow volume loops and examples of flow volume graphs showing a normal spirometry result. So a normal flow volume loop begins on the x-axis, which is the volume axis. At the start of the test, both flow and volume are equal to 0. After the starting point, the curve rapidly mounts to a peak, That is your peak expiratory flow, and after the peak expiratory flow, the curve descends as the flow decreases and more air is expired. A normal non-pathological flow volume loop will descend in a straight or convex line from the top of the PEF to the bottom of the FEC. In children, the expiratory loop can be quite convex due to the increased elastic recoil of the lungs, and this can be seen in figure 9.3b. A frequent variation of the normal flow volume loop is the so-called shoulder, which is a bulge at the outside, high on the curve, and that again can be seen in figure 9.3b, which is on the right-hand side. Figure 9.4 shows normal spirometry test conducted on a 4-year-old boy. Note that the convex shape of the forced expiratory flow segment of the flow volume curve, which is often seen in healthy children with high elastic recoil. Such children can empty their lungs quickly and may not be able to hold on to an expiratory plateau for 1 second. Note that the complete expiration was attained in this instance in less than 2 seconds, even though the plateau was not held for 1 second. In this patient, the FEC was provisionally acceptable following this maneuver and was judged to be acceptable when found to be within 100 mils of the FEC from subsequent maneuvers. Another way of representing the spirometry test is through the volume time graph. If you take a look at figure 9.5, this shows an image of a volume time graph of a normal spirometry test. The start is at coordinates 0 to 0, so in other words, time is 0 and flow is 0. Since most of the air is expired at the beginning, when the child empties his or her airways, the graph rises rapidly. As the lungs are emptied, the rise in expired volumes gets lower and lower to the end in a horizontal level. Because of the high elastic recoil and relatively large airway to diameter to volume, in children, they can empty their lungs very quickly, and often to do this in less than 3 seconds, and they may not be able to hold a plateau for a full second. In figure 9.6, you will see a normal spirometry and graphical representation of the key measurements. Now, what you see on the numerical values of a normal spirometry result is that the FEV1-FEC ratio is equal to or above the lower level of normal, being a Z-score of minus 1.64, or in younger children, round about 90%, and in older children, round about 80%. And these expected percentages on the ratio are on a sliding scale depending on age. The younger a child is, the higher the ratio will be of the FEV1 to the FEC, and that will decrease with age right up until old age or when a patient actually passes away. So in a normal spirometry result, the ratio must be above the lower level of normal, and then the FEV1 must be above the lower level of normal of minus 1.64 Z-scores, or above 80% of predicted, and the FEC the same. It must be above the lower level of normal, Z-score minus 1.64, or 80% of predicted. In figure 9.7, you'll see a real-life image of a normal spirometry test result on a 5-year-old girl. Now again, note the slightly convex shape of the forced expiratory flow segment of the flow volume curve, which can be seen in healthy children with high elastic recoil. Such children can empty their lungs quickly and may not be able to hold that expiratory plateau for 1 second. Note that in this instance, this 5-year-old child completed the expiration in just over 2 seconds, even though the plateau was not held for a full second. In this patient, the FEC is provisionally acceptable following this maneuver because the maneuver is judged to be acceptable when found to be within 100 moles of the FEC from subsequent maneuvers. Let's look at the numerical values in a normal spirogram. So in figure 9.7, this is a real-life example of a normal spirometry test result on a 12-year-old girl. Now, what you can see in this spirogram is that the lower level of normal and Z-scores are circled in red. The best pre-FEC was 2.09 liters, which is above the lower level of normal of 1.73 liters, resulting in a Z-score of minus 0.34. The best pre-bronchodilator FEV1 was 1.68 liters, which is also above the lower level of normal of 1.53 liters, resulting in a Z-score of minus 1.04. The FEV1 to FVC ratio, being 80.7%, is above the lower level of normal of 79.2%, resulting in a Z-score of minus 1.41. So all Z-score results for the three key measurements of spirometry are above the lower level of normal of minus 1.64, and therefore the pre-bronchodilator result is normal. Looking at the pre-bronchodilator result using percentage of predicted, the best pre-FVC is 2.09 liters, which is above the lower level of normal of 1.73 liters, resulting in 96% of predicted. The best FEV1 is 1.68 liters, which is above the lower level of normal of 1.53, and results in a percentage predicted of 86% of predicted. The FEV1 to FVC ratio is 80.7%. This is above the lower level of normal of 79.2%, resulting in a percentage of predicted of 90% of predicted. So again, all the Z-scores and all the percentages of predicted are normal in the pre-bronchodilator test. Looking at the post-bronchodilator test, let's look at the lower level of normal and Z-scores first. You can see the red circles. The best pre-FVC is 2.14 liters, which is above the lower level of normal of 1.73 liters and results in a Z-score of minus 0.15 and 98% of predicted. The best pre-FEV1, 1.84 liters, is also above the lower level of normal of 1.53 liters, resulting in a Z-score of minus 0.43 or a percentage of predicted of 94% of predicted. The FEV1 to FVC ratio is 86.1%, which is above the lower level of normal of 79.2%, resulting in a Z-score of minus 0.57 or 96% of predicted. Good, so I think we've had a good look at normal spirometry there, and hopefully you are all with me. Let's go on to looking at obstructive spirometry. So obstructive spirometry can be seen in children who have lung disease caused by asthma, post-infectious lung disease, bronchiectasis, or cystic fibrosis. It can also be caused by extrathoracic causes such as an enlarged neck mass or vocal cord dysfunction. So figure 9.9 shows an example of an obstructive spirogram and airway. In obstructive lung disease, the airways are partially blocked, so the flow of air will come out slower. This is reflected in a low FEV1 whilst maintaining a near normal FVC. This results in a low FEV1 to FVC ratio. So a reduced FEV1 and an absolute FEV1 to FVC ratio indicates an obstructive ventilatory pattern, and bronchodilator challenge testing is recommended to detect children with reversible airway obstruction, for example in asthma. Figure 9.9 shows a spirogram showing an obstructive spirometry pattern and an obstructive airway. Figure 9.10 shows flow volume graphs of a typical obstructive impairment. You can see the very concave downward curve on the flow volume loop. With reference to figure 9.10, typically a flow volume curve should have a high peak and then a gradual consistent slope down. In an obstructive defect, the peak is often lower and the sloping decline tends to have a concave shape inwards towards the center of the axis. The air in the large airways usually can be expired without problems, so the peak expiratory flow may be normal. When all air is expired from the large airways, air from the smaller airways will be expired. With obstructive lung disease, these airways are partially blocked, so the air will come out slower. This will result in a lower flow and a more or less sharp fall in the flow volume FEV1, and FEF 2575 will be low as well. Typically, the child will have a normal FVC in the early stages of his condition. Figure 9.11 is an example of an obstructive volume time curve and shows us that the volume time curve should have a quick rise to a reasonable volume and then a plateau. In obstruction, the rise is quite slow and reaching a plateau often takes time. So the flow volume curve becomes flatter in obstructive spirometry and the forced expiratory time will be higher due to the lower flow but equal volume. Let's look at the numerical values in an obstructive impairment. So the ratio of the FEV1 to FVC will always be low, below the lower level of normal, that is below a Z-score of minus 1.64, or 80% in older children and 90% in younger children, obviously on a sliding scale depending on age. The FEV1 will be below the lower level of normal, minus 1.64 Z-scores, or below 80% of predicted. And the FVC will be normal, so that will be less than a Z-score of minus 1.64 or 80% of predicted. For any obstructive spirometry result, perform a bronchodilator responsiveness test because this will define the obstructive abnormality as asthma or chronic obstructive pulmonary disease. This will help distinguish between asthma and a fixed airway obstruction and assist in planning management for that child. On the spirogram 9.13, we have a real-life example of a 13-year-old female who has an obstructive impairment. So if we look at the numerical values, the best pre-FVC is 1.94 liters, which is below the lower level of normal of 2.20 liters and results in a Z-score of minus 2.43 or 70.4% of predicted. The best pre-FEV1 is 1.04, which is below the lower level of normal of 2.00 liters and results in a Z-score of minus 4.44 or is 41% of predicted. The FEV1 FVC is 53.45%, which is below the lower level of normal of 82.53%, resulting in a Z-score of minus 4.20 or 55.1% of predicted. On the post-bronchodilator test, the best post-FVC is 2.09 liters, which is still below the lower level of normal of 2.20 liters, and we don't see the Z-score on this printout, but the percentage of predicted post-bronchodilator for the FVC is 75.7%. The best post-FEV1 is 1.20 liters, still below the lower level of normal of 2.00 liters. Can't see the Z-score, but the percentage of predicted is 50.6%. The FEV1 to FVC post is 61.23, which is below the lower level of normal of 82.53, resulting in a percentage of predicted of 56.6%. So this is a clear example of an obstructive impairment where there is positive reversibility following the bronchodilator, which we will go through in Chapter 10. Let's move on to looking at a restrictive spirometry and what you're going to see in restrictive spirometry. So looking at figure 9.14, you see restrictive lung disease means that the total lung volume is too low. Although an accurate diagnosis of total lung volume is not possible with spirometry, because we need to measure residual volume and the total lung capacity, and neither of these can be measured with a spirometer. But spirometry results can be very suggestive of restrictive lung disease. So when we say we think there's a restrictive impairment, we always say restrictive on spirometry, meaning that we know that we haven't confirmed that possible restrictive impairment until we can measure the total lung capacity and residual volume. So people with restrictive lung disease do not have difficulty expelling the air, although the volumes are reduced as the lungs are stiff and less compliant. This results in a high FEV1 to FVC ratio. So let's look at figure 9.15 for an example of a restrictive impairment. Here what you see is a spirogram showing a restrictive spirometry, both on the shape of the flow volume and volume time curves, and showing lungs that are slightly restrictive. Now, causes of restrictive impairments on spirometry in children are pulmonary causes and non-pulmonary causes. Under the pulmonary causes, we have pulmonary fibrosis, post-infectious lung disease, pulmonary edema, lobectomy or pneumonectomy, parenchymal lung masses, and then non-pulmonary causes are skeletal abnormalities, neuromuscular diseases, for example, motor neuron disease or myasthenia gravis or Guillain-Barré, connective tissue diseases, obesity, and often poor technique from not breathing into total lung capacity. Have a look at figure 9.16. This is a flow volume graph of a typical restrictive impairment. In restrictive defects, the peak may be normal or reduced, but the slope tends to be steeper and terminates earlier. Since the airways are normal, the flow volume will have a normal shape. The curve will descend in a straight line from the peak expiratory flow to the x-axis. In figure 9.17, this shows a volume time graph showing a restrictive impairment against a normal spirometry result. The FVC total lung volume is low, either because of restrictive lung disease or because of severe obstruction, and this would be accompanied by a low FEV1 to FVC, and hence would be a mixed pattern, which results in a low FVC. Looking at the numerical values in restrictive spirometry, the FVC total lung volume is low, either because of restrictive lung disease or because of a severe obstruction, and in that instance, it would be accompanied by a low FEV1 to FVC ratio, and hence would be a mixed pattern, which results in a low FVC. The peak flow can be normal or low, and in restrictive lung disease, the FEV1 is equally lowered than the FVC. So the FEV1 to FVC ratio will be normal or even raised. So looking at those numerical values in a restrictive impairment, the FEV1 to FVC ratio will be above the lower level of normal of a z-score of minus 1.64, or more than 80% in older children and 90% in younger children, depending on age. The FEV1 will be normal, or above the lower level of normal, or above 80% of predicted, and the FVC will be lower than the lower level of normal, being a z-score of less than minus 1.64, or 80% of predicted. Remember, to make a definitive diagnosis of restrictive lung disease, the child should be referred to a pulmonary function laboratory for further testing. And then in that instance, if the total lung capacity is less than 80%, the pattern is restrictive, and diseases such as pleural effusion or neuromuscular disease, pulmonary fibrosis, or congestive heart failure should be considered. Have a look at figure 9.18. This shows a volume time and flow volume graph of someone with a restrictive impairment against a normal test result. Looking at a real-life example of a spirometry test result of a restrictive impairment, this one is on a 15-year-old girl, and what we're seeing here is the following. The best FVC is 2.26 liters, which is below the lower level of normal of 3 liters, resulting in a z-score of minus 2.36 and 73% of predicted. The best FEV1 is 2.09 liters, which is below the lower level of normal of 2.30 liters, resulting in a z-score of minus 2.28 and 86% of predicted. The ratio of the FEV1 to the FVC is 92%, which is above the lower level of normal of 80%, resulting in a z-score of 0 and 102% of predicted. So this very clearly shows a restrictive impairment. Let's go on to look at mixed impairments. So if both obstruction and possible restriction are present, then a mixed impairment is possible. And more extensive tests of pulmonary function may be required to determine whether a true mixed impairment pattern actually exists. You can see an example of a mixed pattern spirogram in figure 9.20. Look at the shape of the graph. You can see there that on the x-axis, the patient has actually lost volume, and that the downward curve is concave, showing the obstructive impairment. On the volume time graph, you have a slightly flattened and slightly smaller, lower volume time graph. So in figure 9.21, you can see it as well. The flow volume loop will have characteristics of both syndromes, a lower FVC, as well as an impairment to free airflow through the airways. Figure 9.22 shows a volume time graph showing a mixed impairment against a normal spirometry result. The volume time graph is both flat and flattened. The numerical values in mixed spirometry is everything will be lower than the lower level of normal. So the FEV1 to FVC ratio will be less than minus 1.64 or 80% in older children or 90% in younger children. The FEV1 will be below the lower level of normal of a Z-score of minus 1.64 or 80% of predicted, and the FVC will be below the lower level of normal of a Z-score of minus 1.64 or 80% of predicted. You will see a normal spirogram in figure 9.23, this time of an adult patient aged 56 years old, showing a pre- and post-bronchodilator, possibly mixed impairment test. So especially on the pre-test. So the Z-score results are circled in red and the percentages are predicted in green. When looking at the Z-scores, the FVC is minus 2.45 Z-scores and the FEV1 minus 3.92 Z-scores, and the ratio is minus 3.75 Z-scores. Each of the three main measurements, being FVC, FEV1, and the ratio, are below the lower level of normal of minus 1.64. If using percentage of predicted for interpretation, look where the green circles are. The FVC is 65% of predicted, the FEV1 44% of predicted. Both are below the lower level of normal cutoff of 80% of predicted. And the FEV1 to FVC is 53.1%, which is below the cutoff of 80 to 90%. You will notice that there is no significant change in the results with the bronchodilator either. Look at figure 9.24, which shows a flow volume and volume time graphs showing examples of normal, restrictive, and obstructive impairments in spirometry. Now, what you can see here is that the volume exhaled in the first second is arbitrarily chosen as a measure of airflow, and the ratio between the FEV1 and FVC is used diagnostically to determine whether obstruction or restriction is present. Consider the meaning of a spirometric study that shows FEV1 values and other expiratory flow rates to be just above the lower levels of normal. Step 8. Severity grading. Impaired lung functions are generally graded to quantify respiratory impairment or disability for medico-legal purposes and to optimize and standardize treatment. Now, I don't want you to confuse the severity grading that we're going to look at now with the previous test quality grading that we looked at previously when we were looking at the validity of the test. This is something different. This is about looking at how bad is the problem that a patient has. So the ATS-ERS guidelines suggest grading both obstructive and restrictive ventilatory impairments solely according to the FEV1, as there is little or no evidence for the use of the FVC as a parameter for impairment. Where appropriate, post-bronchodilator FEV1 values should be used for grading, and large airway obstruction should not be graded according to the FEV1. So if you look at the table in figure 9.25, which is proposed by Quanja, Preto, Brazil, and Boris, as the new grading system for the categorization of airways obstruction, comparing percentage of predicted as well as the lower level of normal and Z-scores for interpretation, you will see that FEV1 is the preferred parameter for measuring severity grading of an abnormal test result. There are 5 different severity gradings for the FEV1 when interpreting your test result. So a grade 1 is a mild impairment. And if you looked at the FEV1 would be above 70% of predicted, or the Z-score would be at least equal to or greater than -2. In a moderate grade 2 impairment, the FEV1 would be between 60 to 69% of predicted, or a Z-score of 2 to 2.5. In a moderately severe grade 3 impairment, the FEV1 would be between 50 to 59% of predicted, or between -2.5 to -3 Z-scores. A severe impairment is a grade 4, and it would be between 35 to 49% of predicted, or a Z-score of -3 to -4. And then lastly, you get a very severe impairment, which is when the FEV1 is less than 35% of predicted, or above a Z-score of 4. So this grading table is a nice guideline for understanding how mild, moderate, severe, very severe, or the actual impairment is that the patient has. So let's go back to looking at interpretation and grading step by step, and let's make sure that you get very familiar and comfortable with this. So the first step when interpreting spirometry is to look at your test quality and to validate the data. So was the equipment verified and calibrated? Were the correct reference values used? Was it necessary to correct for ethnic origin? Is the test valid? That means, is it acceptable and repeatable? And was the best test used for interpretation? In figure 9.26, you can see that here's an example of checking the subject entry, the calibration data, which is showing that you haven't made any errors on entering the subject and checking the calibration. In figure 9.27, this is how you analyze the shape of the flow volume and volume time graphs to provide information about the type of ventilatory defect. So the flow volume trials can take on a few distinguishable shapes that correspond to a certain type of pathology. So on the left-hand side, towards the middle of the figure, you can see a normal spirometry test. The first figures of flow volume and volume time graphs show obstructive spirometry. Look specifically for the concavity on the downward curve in an obstructive impairment. In a restrictive impairment, you can see that the test rises steeply and comes down straight, but it's usually very tall and thin. So the patient has lost volume. In a mixed impairment, you have concavity on the downward curve, and you also have a loss of volume on the x-axis. Once you've had a good look at the graphs and you're more or less knowing what kind of abnormality you're expecting, you need to then look at the numerical values. And the best way of looking at the numerical values is to look at the FEV1 to FEC ratio first. If it is below the lower level of normal, or 80 to 90% in children or adolescents, or should I say adolescents and children, this could suggest an obstructive impairment. If it is above the lower level of normal, then it is not obstructive. Okay, so that's the key starting point. If the ratio is below the lower level of normal, then it is obstructive. If it is above the lower level of normal, then it is not obstructive. The next thing you do is you look at the FEC to determine if it is above or below 80% of predicted, or the LLN. You then look at the FEV1 to see if it is above the LLN or 80% of predicted. And if everything to this point is above the lower level of normal, you can stop. This test is normal. There's no need to grade it because you have no abnormality to grade. However, if any one of the FEV1 to FEC, the FEC or the FEV1 are decreased, then there's a strong possibility of lung disease and you need to go to the next step. Let's look at the example in the next figure. So here what we see is what kind of result is this? This shows us a restrictive spirometry because in this instance, the FEV1 to FEC ratio pre-bronchodilator is above the lower level of normal, so it cannot be obstructive. So at this point, it's either normal or restrictive. Then you look at the FEC, and that is reduced. It's below the lower level of normal, minus 2.91 Z-scores. So therefore, I already know that I have a restrictive impairment. In this instance, the FEV1 is also decreased to the same level to a Z-score of minus 2.68, this is clearly in the pre-bronchodilator test a restrictive impairment. If you look at the post-bronchodilator test, let's do it again. What do you do first? You look at the ratio first. The ratio is above the lower level of normal, so it is not obstructive. In this instance, it's either normal or restrictive. I look at my FVC. My FVC is still low at a Z-score of minus 2.73. The FEV1 is also low at a Z-score of minus 2.23. This is also a restrictive impairment. So in this instance, the result is restrictive both pre and post bronchodilator. For any obstructive spirometry result, do a bronchodilator responsiveness study. This will define if the child is responding to a bronchodilator such as in asthma or has fixed obstructive disease. So we will look in more detail at bronchodilator responsiveness testing in the next chapter. Let's look at how to grade the impairment of this real-life example in figure 9.29, which is an example bronchodilator responsiveness test, and I want to look specifically at the severity grading. So we see an obstructive spirometry on both the pre- and post-bronchodilator test results. We look at the FEV1 to grade the severity of the obstruction. The FEV1 is a Z-score of minus 1.90 on the pre-test, and this gives us a grade 1 mild obstructive impairment. If we were using the percentage of predicted for interpretation, we would use 75% of predicted, and this is also a grade 1 mild obstructive impairment. When looking at the post-bronchodilator test, the FEV1 is minus 3.36 Z-scores, which is a grade 4 severe obstruction if you are interpreting using a Z-score. But if you are interpreting using a percentage of predicted, it's 56%, which when you look at it against the table is a grade 3 moderately severe obstructive impairment. So you can see how your interpretation and grading changes using percentage of predicted and the lower level of normal and Z-score. And remember, our preference is always to use the lower level of normal and Z-score. Step F, document your interpretation and comments. So the purpose of recording and reporting is that any person who picks up the spirogram at a later date will know exactly what happened at the time of testing and will have clues as to the factors that have affected the interpretation. So the technician needs to specifically record and report on the following: reason for the test, what the test posture was, only if this differs from what's in the standard operating procedure. What medication has the patient taken that day, especially recent use of bronchodilators? And if medication has been taken, they need to document what drug was taken, the dosage, and the time that the drug was taken. Make sure that people know who the technician was. Write down your name or initials. And then most importantly, comment on the effort, technique, and cooperation that the patient gave during the test. If the child was unable to perform a maximal effort, then this should be noted with an explanation as to the problem. Then what you have to do very importantly before you file this test away is that you have to compare this overall test result against previous test results. Let's quickly look at an interpretation algorithm for the categorization of spirometry. So just to recap on what we've already learned, the first thing you need to do is look at the quality of the test result by looking at equipment calibration and validation, acceptability and repeatability criteria, and where relevant reference values used. Then the next thing you do is look at the FEV1 to FVC lower level of normal. If this is lower than the lower level of normal, you have an obstructive impairment, and your next step is to conduct a bronchodilator responsiveness test. If the FEV1 to FVC ratio is above the lower level of normal, so in other words, it is not obstructive, it is either restrictive or it is normal. And this depends on the FVC. If the FVC is below the lower level of normal, then the test is restrictive. If it is above the lower level of normal, this means that you have a normal spirometry. Thereafter, you grade the impairment. Why would we need to look at longitudinal change over time? So that's looking at the child's test one to the next over a period of time. So serial spirometry testing. What we want to do is look at each test result and establish which was the very best test result the patient blew over a period of time at different testing sessions. And the very best that the patient blew will be the reference of the best that we want to keep the child at. So we will always aim to keep the child at the very highest level that he can be. So really, longitudinal evaluation is important, but can only be done when you have accurate serial test results. That's test results over the time. And this, looking at the data over time, helps medical professionals to make decisions about the child's respiratory health or the need for referral. So longitudinal evaluation is especially important in children who have above normal lung function. For example, they may be way over 100% of predicted or way above the lower level of LLN of Z-score of minus 1.64. But a child may still decline, and if you're not looking at the child over a period of time, if they still fall within the normal limits, you may not realize that he has actually deteriorated from the higher value that he was at to a lower value, but that is still within normal limits. So it's very important that we look at change over time to detect any abnormalities that have come up, even though the child hasn't dropped below the lower level of normal. So when you are looking at change over time, or you're doing a longitudinal evaluation of serial spirometry, you need to make sure that you rule out technical errors. So technical errors would be problems with the blows that are not acceptable or repeatable. You need to make sure that reference values haven't changed over time. You need to look at what equipment was used for testing the child at different testing sessions. It can be quite tricky. So you need to rule out any causes that would have contributed to a change in lung function over time. Let's go to step number 9, which is reporting the spirometry test result. So the purpose of recording and reporting is that any person who picks up the test at a later date knows exactly what happened at the time of that particular test and gets clues as to anything that may have affected the data. So once testing is complete and before the test is stored, there are some strongly recommended comments that need to be made by the latest spirometry guidelines in the 2019 update, and these are what they are. So there are 4 different sections that these comments have been grouped under. The first one is what to report on when the child information is entered. So when you're entering the child's information, it would be great to have options to have no comment, or to say it's the first attempt at spirometry, to say which reference values are used and if an ethnic correction has been used, to say whether the child has used a bronchodilator prior to the test, if it's an adolescent, to say has the child smoked before the test, did the child have difficulty understanding instructions, have they consumed any intoxicants if it's an adolescent child, and are there any symptoms that you've noticed while the child has been with you, such as a cough, a wheeze, a shortness of breath, or any cyanosis or chest tightness. In the next groupings, these are things that you might want to comment on at the end of each blow itself. And that would be no comments, or there might be a cough in the first second of expiration, or glottis closure early termination, hesitation at the start of the test, an obstructed mouthpiece or breathing tube by the tongue or the teeth, a leak around the mouthpiece, not breathing into total lung capacity before they actually blow out, or anything else. So all of these things would be really great to comment on those at the end of each test. Just prior to conducting a post-bronchodilator test, you might want to comment on the protocol, that you do have a standard operating procedure, that the protocol was followed. You might want to document the type of drug that was given, the dosage, and the delivery and method of administration of that drug. You would want to look at post-bronchodilator measurements obtained using a different type of bronchodilator. So say, for example, the standard operating procedure says you should use salbutamol, but you used an anticholinergic, for example, you would want to document that at that time. And then lastly, at the end of the testing session, it would be important to comment on the acceptability and repeatability of the test. So in other words, as a whole, the test quality grading, whether the spirometry caused blowing-induced bronchoconstriction or blowing-induced bronchodilation, if the child was too tired to carry on testing, if the FEV1 dropped by more than 20% from baseline, if there were any motivation or coordination difficulties, or anything else that you might want to add. So, very important that we do comment on exactly what happened at the time of the test so that we can interpret the result according to that, and taking into account all the various things that can happen to make the quality of the data slightly less than we might want it to be, and we interpret according to that. And then lastly, when it comes to the 10 steps to checking your spirometry, step number 10 is storing your spirometry and related records correctly. So every workplace must store their records in a different way. So storage should be such that easy retrieval of the information, the test, and matching the calibration reports to the actual spirometry test is possible. And this way, later on, records retrieval and troubleshooting any problems with the test will be made easy. So records with regards to equipment. You need to at least know somewhere what the type of spirometer is, the model of the spirometer, the serial number, and the manufacturer's warranties for that particular spirometer. You'd want to have your spirometry manual on hand. You would want to know dates and versions of the computer software, so the spirometry software. You would want a quality control log of all the calibration records. You would want any routine maintenance records, upgrades, repairs performed, and the results of these on record. When it comes to personnel records, the minimum you should keep is the technician and the manager's training records. So you want to know when the people trained, and you want to see their certificates of competence. You want to see refresher training certificates. You want records of on-the-job audits and the feedback that was given to the technicians. And then you want records of the technicians who are doing CPD, continuing professional development. All of that will be kept on record. Then lastly, the test reports itself. On every test report, you want to know who the technician was who conducted the test. So the name, the date, and the time of test must be clearly visible on each test report. Paper copies should be kept carefully. If they are on thermal paper, they must be copied. And if you are keeping digital copies, then they should be stored in the computerized system, but you should have a backup plan for your digital storing facility, possibly kept off-site or away from the actual computer itself, so that the reports generated can be saved indefinitely and you can get easy access to data at the end of it. And now it's over to you. I will give you some examples of these 10 steps to checking your spirometry on various test reports that you can browse through at your leisure to make sure that you have a full understanding of everything that we've discussed in the post-testing evaluation and interpretation of that test result. I'll see you shortly for Chapter 10.